GPS Malik, and I am the
just a
moderator Shalini. And please, Rahul.
Yes, sir.
Start.
Yes, sir. Good morning, everyone. Now I request Sukanya Saha to give a talk on an unconventional approach to treat a case of mechanical ptosis due to large chalazion. First one, sir.
Mike. Hello. Good morning, everyone. Here's presenting you on a case series of an unconventional approach of large chalazion with mechanical ptosis. A chalazion has been all known as an idiopathic sterile chronic granulomatous inflammation of the meibomian gland. Incidence of chalazion is 0.24%. It's found higher in females. Ptosis is an abnormally low position of the upper eyelid margin determined while the eye is looking in primary gaze. Large chalazion can induce mechanical ptosis. Intralesional steroid injection has been reported to be effective with high success rates. Aims and objectives of our study: primary is complete resolution in size of the chalazion. Secondary objective, correction of the mechanical ptosis, and follow-up for 6 months for any signs and symptoms of steroid toxicity and recurrence. Treatment options available: warm compression, medication, surgery, corticosteroid injection. Surprisingly, 1/3 of the chalazion resolves spontaneously with conservative management with hot compression. Methods used: study design is a single-center prospective, non-randomized interventional study. The population includes all cases encountered in OPD confirmed to have been chalazion without the need for biopsy. Inclusion criteria includes all age groups, both sexes, large primary chalazion with mechanical ptosis, patients not willing for surgery, and chalazion located close to the lacrimal puncta. Exclusion criteria includes history of large surgery or trauma, multiple chalazion, recurrent chalazion. Total sample size taken is 5 patients in which we gave intralesional triamcinolone 0.1 to 0.2 ml. If there was any residual chalazion left, injection was repeated at 2 weeks interval until complete resolution and 6 months follow-up for steroid toxicity or recurrence. Here are the pictures of pre and post intervention of a female patient which needed 3 subsequent doses of injections 2 weeks apart for complete resolution. Here are the pre and post interventional pictures of patients which showed excellent results after only 1 dose of injection triamcinolone. The results were based on the lesion size, including digital color photography, lesion regression or recurrence, and complete ophthalmic examination, including margin reflex distance, palpebral fissure height. The clinical characteristic of the studied patients: mean chalazion size taken was 0.8 mm square. 4 of our patients showed complete resolution, and only 1 patient needed 3 doses 2 weeks apart. Here are the complete ophthalmic investigations of pre and post interventional values of our patients. We can see that only 3 doses are needed in 1 patient, whereas 4 patients resolved after only 1 dose. Here are the statistical values. Now coming to the discussion part, in Pavlicic acid loss study, we can see that 35 cases required only 1 or 2 injections, and Castrain showed excellent results, 88% cases. Pizzarello study, it showed 7 chalazion resolved within 2 weeks with only 1 injection and other 6 after 2 injections. Whereas in our study, only 1 patient needed 3 injections and 4 cases resolved after only 1 injection. Regarding steroid toxicity and recurrence, Pizzarello and Palva and Pojolvento, 2 cases, recurrence was there, and in Palva and Pojolvento, 6 out of 20 cases recurred after 3 to 6 months. But in our study, there was no recurrence as well as no steroid toxicity. Conclusion: intralesional triamcinolone is found to be a safe, convenient, and alternative to chalazion surgery. No recurrence were reported in our study. Caution: hordeolum must be ruled out before triamcinolone injection. For those in recurrent chalazion, sebaceous cell carcinoma should exist a suspicion, high index suspicion. Limitations of our study: the sample size of our study was very small, short follow-up for 6 months, and it's a single institutional study. Thank you.
We can decide that, let's do all the papers and then we can discuss little bit and I'll show I have devised a MGD roller. So I'll show you my small, this one on that. And that thing I will cure your all MGD problems and all clesions. But this kind of clesion I will excise its wall in one go and then no recurrence forever. The wall is the one which is remaining epithelium and it grows again and again. So we will discuss I think in the end. Next please.
Yes, sir. Now the next talk, Dr. Anamika Das. She is there? She is not there. Then next is Rakhi. Next is Nitin Moitra. Yeah, please. He will be presenting on the misdiagnosed case of orbital non-Hodgkin's lymphoma.
Good morning, everyone. I am presenting a case of a 60-year-old male patient who came with the OPD with the complaints of decrease in vision both eyes and painless swelling around the eyes and the face. And patient gave history of various consultation for the swelling. There was a history of buccal mucosal biopsy and the diagnosis was non-specific sialoretinitis and patient was under treatment for amyloidosis. Patient also gave history of cataract surgery in left eye elsewhere and was left aphakic. On examination, the right eye was having significant cataract, nuclear sclerosis grade 3, and the left eye was aphakic with aphakic bullous keratopathy. On examination of lid and adnexia, a firm non-tender rubbery swelling, rubbery mass was palpable in both the eyes, and there is a marked narrowing of the palpebral aperture. Bilateral lacrimal gland enlargement was present, and there is also generalized enlargement of palatal glands in the salivary glands. All the laboratory tests, the general blood picture was normal, and the viral markers were normal. Montauk's negative, serum ACE and serum ANA was negative. The differential diagnosis were orbital lymphoma or Mikulicz syndrome, or it could be a case of an orbital pseudotumor. When we did the MRI orbit, there was a moderately well-defined homogeneous mass which was molding to the adjacent structure without bony involvement, and predominantly the lesion was anterior to the preseptal and the lacrimal gland. We went ahead with the orbital biopsies of both the orbits, and on histopathology, it was suggestive of large nodules of lymphoid cells which was separated by fibrous septa, suggestive of lymphoproliferative disorder. We get the IHC done and it confirms it is a B-cell non-Hodgkin's lymphoma with a follicular lymphoma type, and the IHC shows it is CD20 positive and BCL2 positive. On the FDG PET scan, it was found it is a metabolically active soft tissue component in both the eyelids with zygomatic region, buccal region, bilateral tonsil parotids, and the mediastinal lymph nodes as well as abdominal lymph nodes, showing a widespread involvement. So the final diagnosis was a stage 3 non-Hodgkin's lymphoma follicular type, and the patient was consulted with the oncologist and he was started on chemotherapy and immunotherapy. It is after 6 cycles of rituximab and bendamustine, and the patient gave an excellent response, and presently he is on the maintenance therapy of rituximab. Post-chemotherapy PET scan shows there is no evidence of any metabolically active lesion at present. So the orbital lymphomas are mostly the non-Hodgkin's, and 80% of the orbital lymphomas are low-grade B-cell non-Hodgkin lymphoma, mostly the MALT type, but our case was a follicular type. So the take-home message is that the orbital biopsy, it helps in making definitive diagnosis, and it also provides tissue for immunohistocytochemistry, which helps in diagnosis and planning the treatment. As our case was CD20 positive, so he responded very well to the immunotherapy of rituximab. Thank you.
Thank you. The next presenter, Dr. Nitish Arora. And he will be presenting on the fixing the skewed in the blue eye girl.
Fixing the skewed eyes.
Yeah, skewed eyes.
Dr. Nitish Arora. I'll be talking about fixing the skewed in a blue-eyed girl. So my case is a case of a 9-year-old girl who presented to my OPD with chief complaints of change in color or pigmentation of the eyes and squint appearance. So on external examination, the presentation was diffuse iris hypopigmentation, telecanthus, mild cyanophorus, that is unibrow, congenital white forelock, which is not seen in this picture, presented for treatment of heterogeneous iris color and squint appearance. She was complaining of squint. So on examination, she was having a vision of 6/6 and eyelids show medial canthal rounding and telecanthus. Other findings were all normal. On fundus examination, we could this is external photography where left heterochromia iridium can be seen. On fundus examination, there is a junction of hypopigmented choroid and a normal choroid, and on autofluorescence, we could see the area of hyperautofluorescence. So a diagnosis of Waardenburg syndrome type 2 was made on the basis of these are the in Waardenburg syndrome. It is a group of genetic condition that can cause hearing loss, which is present from birth, congenital. Changes in the color of the hair, skin, or eyes. Pigmentation is not there. Pale blue eyes or different colored eyes, such as one is blue and other is brown. Sometimes there is segments of two different colors in the same eye, and distinctive hair coloring. The features of Waardenburg syndrome vary among affected individuals and even among in the same family also. So the types of Waardenburg syndrome, in type 1, there is widely spaced eyes, that is called telecanthus. Second, in type 2, there is hearing loss, sensory neural deafness alongside type 1. In type 3, there is abnormalities of arms and appendages like arms and hands in along with type 2. And in type 3, there are gastrointestinal symptoms like blockage or constipation-like symptoms in the patient. So patient's mother also had telecanthus, but which was not a complaint, it is an incidental finding. So our plan was to give a better look to the patient. She was complaining of pseudosquint and telecanthus and was offered a cosmetic contact lens thereafter. So audiometry was done and she was diagnosed with sensory neural deafness, and gastrointestinal examination was normal for her. So our plan was to do a CU-plasty for her. So surgery was done under general anesthesia. Firstly, the ideal intercanthal distance was calculated, which should be at least half of the interpupillary distance. And due to post-operative fibrosis, we planned to excise 1.5 times of the amount of desired correction. So amount of telecanthus correction needed in each eye is half of pre-operative ideal intercanthal distance minus IPD. So the calculations were made and the distances were calculated and the excision was done. So markings of the surgery were done and surgery was performed. But what to do about the medial canthal rounding? So fixation of the medial canthus can be done by fixation of a transnasal wiring, which is quite a traumatic procedure, and fixation of cantilevered mini plate, which requires too much of instruments like striker and a mini plate, which has to be customized. So we planned to give a non-traumatic, not much traumatic, like fixation of medial canthus by medial canthal tendon plication. So the procedure was done, and post-op day 1, she was like this with some edema. Post-op day 7, the look was better, and on post-op day 21, she had a good outcome. As per, we were able to achieve increased distance between two medial canthi, correcting the telecanthus, and we were able to achieve the angulation of the medial canthus alongside increased medial scleral show, correcting pseudosquint appearance. So the aim was achieved of improving the appearance, making it less traumatic, and patient was happy and was given colored contact lenses later for heterochromia. Thank you.
Next presenter.
These kind of cases should be in larger halls really. They are, eye openers for everyone.
Yes.
Yeah. Putting them in this kind of hall is a crime.
I know.
They should be in big halls.
Yes.
People should know that these kind of conditions do exist. They do happen. And we used to do the masquerade, that mustardi, that one.
Double Z plastic.
Yes. And that does wonderful things, and you can fix these ligaments on the periosteum also. But cut it and fix it. Wiring, I hate. Never.
Yeah. Thank you, sir, for your comments. Next presenter is Pratyush. Yeah, please. He will be presenting on the chronic dacrocystitis in cystic fibrosis, a novel ocular manifestation.
Good morning, everyone. So this is a case report of chronic dacrocystitis in cystic fibrosis case. Brief introduction. Cystic fibrosis is an autosomal recessive disease caused by the mutation of CFTR gene on chromosome 7, mainly affecting lungs, pancreas, liver, sweat gland, and vas deferens. Ocular manifestations are uncommon, and chronic dacrocystitis has not been previously documented in any population. I here present the first case, emphasizing the need of heightened awareness among clinicians. So a 28-year-old female with a confirmed diagnosis of cystic fibrosis who had undergone right lung lobectomy due to pulmonary complications of cystic fibrosis at the age of 22 years. Her chief complaint was persistent watering and swelling and redness over the medial canthus of the right eye for the past 7 days. So there was recurrent tearing and occasional discharge over the past 6 months. Other history, significant history involved systemic history. The patient had undergone right lung lobectomy and had no other systemic involvement at the time of presentation. Drug history involved, the patient had taken a combination drug of lumacaftor and ivacaftor along with bronchodilators and inhalational steroids. Oral and intravenous antibiotics were only administered in cases of exacerbations. Patient belonged to lower middle class background. Pallor icterus cyanosis were absent. Lymph nodes were non-palpable. Clubbing was present. Systemic examinations include coughing, nasal congestion, and because of repeated episodes of pneumonia, the patients had symptoms like fever, coughing, shortness of breath, loss of appetite. The other systems, which included GI, nervous, and cardiovascular systems, were normal. Among the ocular examination, the vision, pupil, the conjunctiva and sclera, cornea, and the posterior segments were normal. The positive findings included the lid adnexia, which presented with tenderness, erythema, with sinus tract over the right medial canthus, and syringing gave us a regurgitation from the upper puncta. So for the management, we started with topical antibiotics. We started with moxifloxacin QID. Systemic antibiotics, comoxiclav was given twice daily. And then for the surgical management, we started with external DCR with sinusectomy of the right side. So this was the post-operative day 1 image, and this was the 3-month post-operative image of the patient. So to the best of our knowledge, this is the first reported case of dacrocystitis in cystic fibrosis. Although cystic fibrosis primarily affects the exocrine gland, including those in the respiratory and digestive tract, the involvement of the lacrimal system has not been well documented. Possible mechanisms may include altered mucin composition affecting tear duct function or increased susceptibility to bacterial colonizations due to impaired mucociliary clearance. So we conclude this case by stating that this was a rare occurrence of chronic dacrocystitis in cystic fibrosis case, challenging the conventional understanding of cystic fibrosis related manifestations, especially ocular manifestation. Further research is essential to delineate the pathophysiological links between cystic fibrosis and lacrimal system involvement. Thank you.
Comments? Okay. Next is Dr. Rahul Shukla is there? Yeah, please. He will be presenting on the unilateral ptosis in a pediatric patient secondary to ocular myocystic.
Good morning, everyone. Brief introduction about my topic is cysticercosis, the larval form of Tinea solium. It is endemic in the tropical areas such as Sub-Saharan Africa, India, and East Asia. Affect almost all eye tissues. I am presenting a 6-year-old girl with painless progressive increasing drooping of the left eyelid for 1 month. The history of fever on and off for 1 month. Patient was vegetarian by diet and no history of any traumas found. On examination, the left eyelid revealed severe ptosis in swelling. Anterior and posterior segment examination was within normal limit. On general and physical systemic examination was within normal limit. On ptosis evaluation, right eye was within normal limit. In left eye, eyelid crease was absent. MRD1 was minus 0.05 mm. MRD2 was 5 mm. Levator function was found 2 mm only. And Bell's phenomena was present in this my patient. Onyxocular movement was full, free in all 9 cases. Palpable fissure voice was not obtained in the left eye. And ultrasonography shows the hypoechoic cyst with hyperechoic scolex in the LPS muscle. On blood investigation, grossly within normal limit, but eosinophilia was noted. And ELISA for the serum antibody against cysticercosis was positive. On the history and physical exam diagnostic test, my probable diagnosis was found that ocular cysticercosis involving the levator palpebri superioris with acquired mechanical ptosis. After diagnosis, we are treating with albendazole 50 milligram per kg per day for 1 month with oral steroid prednisolone 1.5 milligram per kg per day in the tapering doses for 1 month. This picture showing when the patient comes to us with the severe ptosis. After the 4-week, this improvement was noted. On serial ultrasound imaging, I was found the initial ultrasound was like this: hypoechoic cyst with the hyperechoic shadows, and after 4 months, this is complete resolution was found. This is the picture which is showing after the 4 months with complete resolution. There was no lagophthalmos found in my patient after 4 months of the treatment. The first visit, I am comparing the first visit with the 4th month follow-up case. MRD1 was minus 0.5 mm. After 4 months, there was 3 mm MRD was found. MRD2 5 mm and complete gain after the 4 month. Levator function 2 mm, which gain at 12 mm. Extraocular movement full, and palpebral fissure height was 9 mm. This is the ultrasound of when patient visit to us. This is the initial ultrasound, and this is the subsequent follow-up ultrasound finding. The take-home message for my patient is: ultrasound B-scan is involved in effective tools in supplement clinical diagnosis and monitoring the effect of treatment in case of ocular cysticercosis. Acquired mechanical ptosis secondary to cysticercosis managed conservatively result in nearly complete resolution after the treatment.
Dr. Rahul, one thought came in my mind that the patient presented to you with unilateral ptosis.
Yes,
then how the thing came in your mind that the patient may harbor cysticercosis? So was there any edema redness? Because normally whenever the worm, it infiltrates the tissue, apart from the ptosis, it creates some other ill effects of the inflammation. So whether that were not commented or whether they were present, or how it came in your mind that there was a cysticercosis, because it's not a congenital or other sort of a differential diagnosis. That we want to clear it off.
It was acquired ptosis, no?
Yeah.
Acquired ptosis, sir.
Acquired ptosis, MRI to karai.
Yes, sir. Yes.
I think he found in it.
Sir,
I'm just asking that albendazole is given for so long
Yes, sir.
these days. Albendazole.
Yes, sir.
Because they have toxicity, sir.
Yes, it is quite toxic.
They
and,
have toxicities.
Another thing I'm warning that some very enthusiastic oculoplastic surgeon to get 60,000 rupees will operate the ptosis.
Yeah.
Yes.
So that so that happens at times. So people really at times, suppose he doesn't do anything, he doesn't examine much, doesn't do MRI, and he feels scared. First I correct it and then I'll see what it is.
Yeah, it is wrong.
So cysticercosis will be found later on. So good one, very good case. Again, they
Thank
are
you, sir. Thank you so
wonderful
much.
case. Yeah.
Yeah, thank you, sir, for your comments. The next presenter is Ayushi Chauhan. Yeah, she will be presenting on mystery of the missing eye.
Good morning, everyone, and thank you, AIOS, for giving me the wonderful opportunity. I'm Dr. Ayushi Chauhan, second year resident at Baroda Medical College, Gujarat. Here are some introduction points. Traumatic globe dislocation is a very rare clinical presentation and most commonly seen after the road traffic accident. Orbital wall fractures along with the frontal bone fractures are associated with the dislocation of the globe into the cranial cavity. Here I'm presenting a case in which we could not only achieve the cosmetic restoration but also the post-operative vision. Coming to the history part, a 30-year-old male patient residing at Vadodara presented in the casualty department with a history of road traffic accident with injuries over the head, face and both the eyes. On examination, there were the extensive facial injuries extending from forehead and involving the upper and lower eyelids of both the eyes. On general examination, patient was conscious, cooperative and oriented, and patient's vitals were normal. Here are some of the photographs of patients on arrival. As you see that there is the extensive forehead flap present with multiple lacerations present over right eye and the left eye. On opening the right eye, no globe-like structure could be seen in it, only the bony fragments and hemorrhage could see. Left eye was normal with a vision of 6/6 and anterior and posterior segment normal. We go through the primary investigations in which the computed tomography scan of the brain in 3D CT phase was done, in which eyeball on both the sides was intact and with intact optic nerve with slight displacement of eyeball with frontal bone fracture. As after following the diagnosis, we primary suturing the laceration in the emergency department. Then we take patient to the further surgical management along with the neurosurgeon to reposit the globe in the orbital cavity. When the neurosurgeon raised the flap, and further exploration done to find out the eyeball. The eyeball was found in between the bony fragments and slightly displaced upward through the defect in the dura mater. Then we sutured the lacerated orbital tissue and try to reposit the globe into the orbital cavity, and the further defect in the dura mater done by the neurosurgeon. Here are some intra photographs of the patient, which was reproduced after taking consent of the patient. This is the immediate post-op photograph. After 1 month, patient's vision in right eye was 6/9 with complete ptosis and enophthalmos, but with an absolutely normal anterior and posterior segments. CT scan of the head and orbits provided a detailed location of the luxated eyeball and provided guidance in further management of the case. As in our case, after the CT scan, we could know that their eyeball was present there. Before that, it was a mystery for us where was the eyeball. In such scenario, early diagnosis and immediate globe repositioning is crucial for patient's visual recovery if the optic nerve is found to be viable. Early intervention is the key to salvage such eyes in view of the psychological benefits and for cosmetic reasons. Thank you, everyone.
Any
Comment
comments?
is that only really that I would suggest that in main halls, this kind of one case at least after every session, let it be in the last.
Yes, sir.
But these kind of rare cases must be known to whole people,
Yes.
that you can come across something in the life like this, which you have never seen, never being discussed anywhere. So discussed here means a lot of delegates would not know that there are cases like this, and especially younger ones. We like people have seen everything. We have seen the no eyeballs in the children in few villages in Bihar around a river. There are 3-4 villages where the eyes are missing since birth, either one eye or both eyes. I was taken there by a Bihar doctor, and then American team came, ICMR team came. I don't know what happened then. I wrote to ICMR also, find out what is happening there. There are, like I saw, at least dozens of children with missing eyes. Anophthalmos completely, both eyes or one eye. And they were not genetic, like not one family. The bride was from somewhere else, bridegroom was somewhere else. And I don't know, really, it's worth visiting those areas if you are keen on that. So I'm saying these rare kind of things must be shown to the wide delegates present, that this thing can come to you. And don't operate ptosis, look for cysticercosis.
Yes, sir. Yes, sir. Thank you,
Next,
sir.
please.
Thank you, sir, for your comments. Next presenter is Akash Agrawal is there? Yeah, please come. He will be presenting on the catastrophes of an implant malposition.
And speakers or presenters must remain here to
Yeah,
face little bit of, we don't
Discussion.
grill you, we just
discussion.
teach ourselves that you read it more than I have read. So you know it more than me.
Good morning, everyone. I'll be walking you through our case of titled Catastrophes of an Implant Malposition. There are no financial interests. So a 34-year-old male had presented to our OPD with complaints of diminution of vision in the right eye for last 1 year. And the only significant history was he had a titanium mesh implant for an orbital roof repair was done following an RTA 12 years back. So on examination, vision in the right eye was reduced 6/9, left eye was 6/5. Color vision was normal and Hertel's was comparable. So on primary gaze, he had a 5 prism diopter L over R. On up gaze, he has a -3 elevation limitation, and the squint was a 20 prism diopter L over R. Down gaze and lateral gazes were all normal. He had a lag of ophthalmos of 3 millimeters. He had poor bells, and you can clearly see in the cornea signs of exposure keratitis. So a CT scan was done, and we could see the original implant was impinging on the globe, as well as the LPS was noted to be thinned out. So a diagnosis of right eye implant malposition abutting the globe was made, and the patient was planned for right eye implant trimming via lid crease approach until general anesthesia. So intraoperatively, we noted that FDT was restricted superiorly, and the titanium mesh was seen abutting the globe superiorly, and there was extensive adhesions and scar tissue present. So we removed 4 small islands of the implant. So this is preoperative. You can see the patient, and this is post-op photo. This is at 1 year follow-up. The patient is now orthophoric. The lag of ophthalmos is completely resolved. His up-gaze motility restriction is also resolved. He has now good bells, and his cornea, you can see it sparkle. It's totally clear, and he has now 6/6 vision. So orbital roof fractures are rather rare, comprising of 1 to 9% of orbital wall fractures, and 60% of patients usually require surgical repair, with titanium mini plates being the most commonly used implant in 46% patients. Some common post-op complications include some post-op edema, chemosis, vertical movement limitation, enophthalmos and exophthalmos. As per our knowledge, this is the first case to be reported in which a patient developed poor bells due to direct impingement of the globe by the implant. A review of literature was done which showed that around 6.5 to 17% patients post-implant require revision surgeries due to a variety of complications which I previously mentioned. And in most cases, the surgery or revision surgery is done within 2 months. But in our case, the patient presented after 12 years of his primary surgery. So in conclusion, we need regular follow-up post-implant surgery to look for implant-related complications. Patients can present late in case of elevation limitation, as did in our case, because they are able to manage their day-to-day activities, as the patient did not have any diplopia in primary gaze or on down gaze. So they are able to go about their daily lives without much difficulty. Impingement of the implant over the globe can alter the Bell's phenomena, as it did in our case, and this can further lead to exposure symptoms. And thorough clinical examination and imaging helps clinch the diagnosis and appropriate management. Thank you.
Yes. So definitely this displacement of implants is a big problem in such cases, and wherever you have to cautiously place and monitor the patient regularly, otherwise not just merely doing the surgery and just forgetting the follow-up of the patient. So patient can land up with problem which we had already now seen. Thank you very much. Okay, sir. Yes. Next presenter, Dr. Swati Tripathi is there. Okay, she is not there. Then Anjori Gupta is there. Yeah, yeah. She will be presenting Anjori Gupta on the
ball
or
masquerade.
what is
The ball masquerade.
ball masquerade. That's from pronunciation. I was getting it a little bit confusion. Anyway, please.
Good morning, everyone. Today I'll be presenting a case, titled The Ball Masquerade. So a 12-year-old boy came to the emergency with sudden painful progressive prominence of the left socket since 1 week. He has a history of evisceration with ball implantation done 4 years ago. He had undergone multiple socket reconstruction surgeries with mucous membrane grafting and AMT, and he was treated for orbital infection prior to the last surgery. On examination, the right eye was, vision for distance was 6/6, and the near vision was N6, and the anterior and the posterior segments were within normal limits. The left socket showed gross proptosis with raised retrobulbar resistance, and the inferior and the superior fornix were obliterated. MRI was done for the patient. In T1 weighted image, we could see a spherical ball implant which was superior-temporally migrated due to a ISO2 hypointense cyst around the ball implant. And a similar image was seen in the T2 weighted image, where a homogeneous hyperintense cyst was seen around the ball implant. So our case was managed with aspiration of the cyst, followed by intralesional injection of the cyst with bleomycin and sodium tetradecyl sulfate.
The cytology of the cystic fluid showed mixed inflammatory pathology. This is the presentation of the child after 2 months with resolved symptoms, and we can see a significant decrease in the proptosis, and similarly it was seen in the CT that the implant was surrounded by significant reduced cyst. So some common causes of proptosis in children are malignant lesions, orbital infections, Graves' disease, and benign tumors. So implant cyst is a very rare complication in anophthalmic sockets, and the most common presentation is inability to retain prosthesis with proptosis. And it has been seen up to 7% patients with orbital ball implants can have a complication of implant cyst. And it has been also seen that they frequently develop after a secondary ball implant. And the proposed mechanisms for the development of implant cyst are implantation of a free conjunctival fragment into the deeper orbit, forming the lining of the cyst, or incarceration of the conjunctival edge in the wound closure, or a conjunctival dehiscence followed by epithelial downgrowth forming the cyst. So management in such cases is challenging, and literature has showed that complete excision of the cyst with or without implant removal or marsupialization in cases of small cyst are the gold standards. But another conservative alternative treatment option is cyst aspiration with intralesional injection of a fibrin ciliate, which we did in our patient, which has resulted in a complete cyst resolution or aid in en bloc excision. And the similar results were seen in the literature review, where 2 papers have showed that they've used sclerotherapy as the treatment option, giving positive results. And according to my research, this has been the first case presented in India, and that makes it rare. So to conclude, sudden onset proptosis in children may not always be infectious. A rare complication of orbital implant cyst should always be considered. Imaging helps in diagnosis and planning the appropriate treatment. Thank you.
Thank you. Comments?
And I think people do know that this implant, orbital ball implant, do get away. The extrusion is one very common complication. I used to, those old days I used to do that if I have to do inoculation, why not I save the sclera, bit of sclera with muscles, and remove the rest of the complete kind of a evisceration, but not complete. And then it was called that time frill excision, that you can leave little bit of sclera and muscles attached to it, and then you suture them well with conjunctiva and everything. And if there is a shortage of conjunctiva, you can put a label graft or something else. And then you put an implant that is just contact lens type of implant. And it moves so well. And you don't have complication of any of these balls at all. And I never practiced the ball because I was never sure of this, neither material, its quality, its properties, its inflammation, this one. And then extrusion, of course, was the commonest problem.
That's the most common complication.
So we used to get in long time in 80s at Sitapur that it has been thrown out and then do something. Yeah. So I at least did that remain part of sclera with muscles, and then suture it and make the socket very well with conjunctiva. Shortage hai to wo badha diye thoda sa. You can put that little bit of mucosa from anywhere. And then put a contact lens kind of implant which is designed with color of this another eye. And it was done in Aligarh by a lady. She is no more there, I think. Sanno Devi, Sanno Rani. Sanno Rani or Sanno Devi? Sanno Rani कहते थे हम तो. रानी थी. अच्छा. वो देवी थी शायद बाद में हमने. अच्छा. तो सन्नो रानी जी तुम्हें बुलाती थी. वहाँ पे बच्चे का या किसी का भी वो डिजाइन उसी कलर के साथ करती थी. So she was artist. Her husband also did for some time, but now I think tradition is not there. You can start, any of you.
You said that it's a first case in India.
Ma'am, in children.
In children?
Yes,
okay. In adults we do get.
Yeah, adults, ma'am, it's more common. Okay. Only first case in India in children.
Reported?
Yes, ma'am.
देखो कितनी हमारी बुद्धि बढ़ाई आपने ज्ञानवर्धन.
Thank you. The last presenter, Dr. Ravish, is there. Ravish Bindal. Okay, he is not there. So again, the earlier 2 people who could not present. Sir, Ravish is not there, sir. Last one. And then the earlier 2, Anamika Das is there. Last chance for her. And Dr. Rakhi is there. Okay, so total 4 are absent, sir.
I think session is, virtually understood by everyone so well, and again I emphasize on that. This should have been, all delegates must have been exposed to this kind of cases, and I would write to the chairman scientific committee, but ye leaders meri sunte nahi hai, they don't like me much. So I can only, at times I don't shout now, I am not melted down, but I will suggest them that these kind of patients really, end of every session you can put a case like this.
Yes.
So that almost more delegates come to know it. And these cases should be put in something like having in All Indian Ophthalmic Society now, that's happening with APO and all that. If you are not send them. But again वही बात है कि वो चेयरमैन साइंटिफिक कमेटी को क्या पसंद है कि नहीं पसंद है. तो उनको पसंद कराने के लिए क्या करना पड़ेगा, that you have to see.
Yes, sir. Even a junior person is also presenting, and if the case is of a good matter, and really what you are talking, that the thing, all the fraternity should know. So that has to come in the main hall. Yeah.
Yes.
So I also fully agree, sir.
अच्छा, ये सारे केस ऐसे हैं ना, किसी को कुछ पूछना है जो हमारा तजुर्बा है, या हम तो आपसे क्या पूछें, आपने तो हमें पढ़ा ही दिया सब कुछ, जो हमें नहीं आता था. तो but since me like person who was trained in that when there was no glaucoma separate specialty, no retina separate specialty, no squint separate specialty. Now it is still not there. By National Medical Commission, still you don't have any diploma degree for pediatric or retina or glaucoma. So we did everything. Me like person did everything including retina. Retina I gave up 30 years back. So Sitapur was the first center to do retina surgery in India. And Dr. J.M. Pava, Padam Shri Dr. J.M. Pava was the first to do the retinal detachment surgery in India. And that time, the simple surgery was, and still I can say that most effective, that you put a circles, 1 or 2 circles with a 1 or 2 implant, and then cryo around all, so that retina would not detach from periphery, आगे वो hole होता रहे, कुछ भी होता रहे, but तुम्हारा central 30 degree will be intact lifelong.
Yeah, preserved.
So your vision will be 6.9, 6.6 or whatever. You will get much better vision than PPV. PPV also you are getting vision when you have a simple hemorrhage or simple something. Diabetic retinopathy, Dr. Tiwari used to say that you do the surgery and vision will be, he used to say that.
Yes, finger
fingers,
counting
2
meters.
You tell patients that do whatever, you will have finger counting only. So pay but people do pay 1-2 lakh रुपए रेटिना वाले को तो मिलना ही चाहिए, जो मेहनत करता है बेचारा 2 घंटे लगा है. So but some of the old surgeries were still good. They should be really, this surgery I am telling you, rings wala, will save your posterior half of the retina very well, because this pen cryo on the anterior part will fuse it everywhere. एंड होल वोल होगा भी तो अब पीछे नहीं पड़ेगा, बिकॉज पीछे आपने इम्प्लांट भी रख दिया, वहाँ पे वो भी रख दिया, रिंग भी रख दिया, और 1 या 2 एंसर क्लास कर दिए इस तरह से. I remember an episode, Dr. N.K. Jain, you have not heard, who got murdered his wife, and one of the best surgeon of Delhi and North India. So people, why do they get murdered their wife? I don't know. They can get divorced or something. So this man was so famous surgeon of Delhi that when he was in prison for 10-15 years, then people used to come from Punjab, Haryana and so many places of the country that Jain Sahab ko dikhana hai. And Jain was available in the jail, made the arrangement for him to see the patients. And once when he was out of jail, he was operating on retina detachment like that. And I was in Safdarjung, he phoned me, किसी के वो तो उन दिनों मोबाइल नहीं थे, कि डॉक्टर साहब मैं अटक गया हूँ यहाँ पे, एक पेशेंट जालंधर से आया हुआ है, 2 बार उसका रेटिना डिटैचमेंट ऑपरेशन हो चुका है. And then I went there, and it's in garage he has a OT and 1 assistant come driver. So he made the arrangement, and then we put that one circle, put the 1 implant, did the cryo, and this patient got 624 vision for life. He really got it. And another eye he had phthisis or something. He was a businessman from Punjab. तो ऐसी कहानियाँ हैं लिखने वाली हैं, कोई मुझे लिखने वाला मिल जाए तो मैं छोटी सी एक किताब मुझे लिखनी चाहिए.
No, really for the newcomers, youngsters
Yeah,
and the next
but-
generation people, definitely.
Because we, in fact, in this country, I believe that every eye surgeon must know glaucoma surgery, phaco, SICS, and even squint surgery.
Yeah.
Ptosis also I will include in it. In fact, when I was teaching in my days, I saw to it my students learn what I learn. What I know, they must know it. Mostly, who are interested, they will learn squint also, they will learn ptosis also. But at least, कुछ तो जानते ही होंगे, ऋषिकेश वाले भी जानते हैं. And some when I was in Subharti, I saw to it my third year PG must get the 40 phaco independent. 40 to 50 phaco independent. Now see the phacos, people are taught and came out of the MS pass from North India and they are looking for LV Prasad and Madurai and fellowship somewhere to learn the phaco. तो अगर हम टीचर्स की वो है ये तो कि हम इतने मतलब you feel that it is my responsibility as a teacher. But there was a problem, teacher did not know the phaco. Yeah. And he was the examiner and he was the MS teacher. So that was unfortunate. Because he also did not know the phaco and he said phaco is no good. What is there? ECC is very good, 2 suture, 3 suture. So it depends a lot of teachers also. In fact, we started program of the, when I was National Program Control of Blindness Chairman, we started that teachers should be went for phaco training or SIC training to different institutions. We did that. And so many people did learn that, कि at least they learned the phaco. But वही होता है कि जैसे तुम RP सेंटर में जाओ phaco सीखने, तो वो हाथ तो लगाने नहीं देते हो. वो कहते हैं इधर दूर खड़े हो, दूर से, इतनी दूर से देखो, वहाँ देख लो. तो उससे phaco थोड़ा ही सीखी जाती है. Phaco you have to sit with the student and change the chair again and again. You do one step, you make a mistake, you change the position and just say proceed further. That is how phaco is taught. तो वो ऐसे ना गुरु रहे हैं ना ऐसे चेले रहे हैं, तो सीखेंगे जहाँ जहाँ लड़ते फिरते तो 2-4 ड्रॉप हो जाएंगे. न्यूक्लियस क्या है, कहीं ना कहीं तो सीख ही लेंगे. Very good meeting you. And any of the paper, anybody has a questions or something, there are a lot of things one can discuss all of these papers really.
Yes.
I am saying it is too extensive a subject for every presentation and this great job the children have done. Wonderful. Congratulate you all for this and keep on sending them to the international conferences, national conferences. Somebody will have a look at it. And I of course would write to my society that please these rare cases must be shown to people. What was in this hall. So मैं specially recommendation ये तो भेज ही दूँगा. वो मुझे माने ना माने.
Yes.
अपना काम करते रहो. So thank you very much.
Thank you.
Anything-
Thank you. Anything, madam?
Madam, any comment to make on any of these cases? They are all wonderful cases. Thank you, madam. Thank you, sir.
Thank you, sir. Thank you very much, sir. Thank you to all audience and to all the speakers. Thank you.